considered a secondary disorder. So just to kind of recap, if you're a hypersecretion and it's a primary hypersecretion, the hormone is being produced in excess from the primary gland. But if it's a secondary disorder, the hormone is being stimulated by something upstream of it to produce that hormone in excess. And then it would be the opposite for hyposecretion, right? So if it's a hyposecretion, the primary endocrine gland will not be secreting enough hormone. And if it's a secondary hyposecretion, something upstream of that gland is not allowing it to trigger and release hormone. So more often than none, it's the hypothalamic pituitary axis than anything else, right? You know, it's the fact that the hypothalamus may not be sending out enough information to the anterior pituitary, or the anterior pituitary may not be sending out enough information to the adrenal gland, for example. Okay, that would be a secondary disorder. But when we're looking at primary disorders or secondary disorders, that negative feedback is going to be so important, right? Because if our cortisol levels are too low, that's going to trigger the adrenal pituitary, the anterior pituitary, to make more ACTH. That's going to trigger the hypothalamus to make more CRH, you know? Or if the cortisol levels are too high, it's going to basically trigger ACTH to be decreased or trigger CRH to be decreased. So the negative feedback system is going to come in very handy here, right? So make sure that we feel comfortable with that. Another thing that we need to feel comfortable with as well is actually knowing where these hormones are coming from and what they trigger. Because like I told you guys before, you know, it's really about that flow chart, right? You know, here is my gland. What triggers it to secrete? What does it secrete? When it secretes it, where is it going? What does it do when it gets there? You know, that's going to be super important. So just really knowing the different hormones and the steps are going to be important, you know. Does that kind of make sense, guys? So essentially, we're going to be doing a whole bunch of endocrine disorders, regardless if they're hyper or hypo in function. So, you know, it's important that we keep everything kind of straight. So the first thing we're going to do is we're going to look at the diseases of the anterior pituitary. And one of the ones we're going to look at is disorders regarding growth hormone. So the first thing you would do to yourself is you would say, growth hormone. What does growth hormone do? Well, growth hormone and its counterpart, insulin growth factor 1, is pretty much all about upregulating growth of your soft and bony tissues. So if you have a hypersecretion of growth hormone, what's going to happen here? You're going to have excess growth of soft and bony tissues. And that excess growth could be as a child before your epiphyseal plate closes, or it could be as an adult, you know, after your epiphyseal plates close. So acromegaly is a hypersecretion of growth hormone as an adult, and giantism is hypersecretion of growth hormone as a child or adolescent. So why might this happen? This may probably happen because you've got a pituitary adenoma, right? So especially as an adult, right? If you start having symptoms of excessive growth hormone as an adult, it's usually due to the fact that you've got some kind of pituitary adenoma. So just like, you know, any kind of mass in the brain, there's really not a lot of space in the brain overall. There's not a lot of space in the skull to, you know, maintain that much excess tissue. So it tends to start to impinge and compress other brain structures, such as the optic chiasm, which could lead to, blurry vision. And also it's going to increase the overall intracranial pressure, which can cause headache and nausea and vomiting, right? So along with the other symptoms associated with the endocrine disorder, you'll start to see symptoms associated with the actual tumor itself. Does that kind of make sense, guys? So if you have giantism would be, a hypersecretion of growth hormones before the epiphyseal plates close, right? So that would mean that the long bones have the ability to grow, Okay, so a great example of giantism, right, is Andre the Giant. How many of you guys know who Andre the Giant is? So Andre the Giant is, yeah, you know, you've heard of him. Thanks, Andrew. I'm glad you've at least heard of him. So he was a pro wrestler, right? Back in the day, probably before you guys were born. And he was 7'4" tall. He was about 530 pounds. And he was also an actor. He starred in this show in the 80s called The Princess Bride. Exactly. Yes, Ryan. He starred in The Princess Bride. And he suffered from giantism, right? Having this hyper secretion of growth hormone. Okay, so start thinking to yourself, if you have growth hormone being excreted in excess, okay, and it's against the not just the long bones, it's against even the soft tissue. What do you think is going to happen to these patients after a while? Like, you know, what do you think are going to happen to the other organs and the other organ systems? You know, how do you think that's going to reflect on the patient? What do you think is going to be some other clinical manifestations associated, like, with the fact that they've got this increase in the growth hormone, triggering, right, heart failure for sure, right? Their heart, for one, will enlarge because of the growth hormone, and then for two, will fail because it has so much body to actually to supply, you know. So, you know, the enlarged organs in general, yes, Dan, you know. So, you know, you got to think about the fact that the soft tissue and the bony tissue begin to hyperproliferate in these patients, okay? And, you know, that can cause for lots of complication, like lots of different hypertrophies of the different organs, absolutely, okay? But what happens after you're finished growing? So let's say you're an adult and now you end up with some kind of, oh, so Dan's asking a question, does that leave them at risk for neoplasms? Well, it could, right? I mean, it could, I mean, not necessarily, but it could, you know, the growth hormone itself in excess could cause, you know, if they have another, like, if they have like a mutation already. So if they've got some kind of initiator, the growth hormone in excess could lead to like a secondary carcinogen for sure. So, I mean, that's a possibility. But typically the neoplasm associated with giantism, the one that's actually causing the giantism itself, is tends to be a benign tumor. But the excess in the growth hormone can cause for complications like that, yeah. But if the epiphyseal plate has already closed, right? So after the plate has closed, your long bones can't get any longer. Sorry, I'm very tired. Your long bones can't get any longer, right? But the bones can become thicker, right? So look at how his facial features has changed over the time, right? You see how his facial features have become a lot more coarse, okay? And that's because the bones are becoming thicker, right? His internal organs will begin to enlarge, just like you guys said. His larynx and voice box will become thick, so his voice will change over time, right? But with this disorder, which is known as acromegaly, what ends up happening is, you know, you have this excess in growth hormone, probably due to a pituitary adenoma, um, and it causes for excess growth of the bony tissue and the actual soft tissue itself. But you finish growing tall, so instead you kind of grow thick. All right. So that would be our growth hormone, kind of giving you an idea of, you know, kind of like a little preview to what, you know, the disorders would kind of look like. So what about thyroid gland disorders, right? We talked a lot about that before. We talked about the fact that you can have hyperthyroidism, too much thyroid hormone, or hypothyroidism, too little thyroid hormone. So your hyperthyroidism could be because the thyroid itself is over secreting thyroid hormone. Is that primary or secondary, guys? What do you guys think? That's primary.
Primary.
Yeah, absolutely. And then if it's the pituitary that's overstimulating, causing for an increase in the thyroid hormone, that would be secondary, right? Okay. Or sometimes you have what's called an exogenous source, nothing like cancer to secrete a hormone, which is, not only do you have cancer, but now you have like an endocrine disorder. So sometimes ovarian tumors will secrete thyroid hormone as well. So that's something that can happen. And then your hypothyroidism could either be congenital, like you're born with it, right? And typically, if you're born with a hypothyroidism, it's because your thyroid didn't develop properly in utero, or it could be acquired, like maybe you're taking some kind of drug that screws up your thyroid, or you have an iodine deficiency. That's not too common here in the US. Or you removed your thyroid, right? If you have hyperthyroidism, one of the ways you treat it is to take your thyroid out. So if you take your thyroid out, guess what? You don't have a thyroid. So you just went from hyperthyroidism to hypothyroidism, right? So that's another example of how you would acquire a hypothyroidism. But one thing to keep in mind, guys, is the thyroid hormone is extremely important, especially because it acts on all of your cells. It's important for like normal growth and development, um, you know, and because it acts on all your tissues, the abnormality effects are very widespread. So, when we're thinking about manifestations occurring with the thyroid hormone disorders, I'm going to tell you from now, it don't make no sense you memorize the list, because it's going to include things in the cardiovascular system, in the integumentary system, in the GI system, in the musculoskeletal system, in the neurological system. So just kind of like, you're gonna have to just think about it, because that's a lot of memorization. So Hashimoto's would fall into an acquired hypothyroidism, because with Hashimoto's, your thyroid actually gets destroyed by your immune system, so you don't make enough thyroid hormone, Andrew. So Carrie's asking hyper or hypo for which one? In terms of what, Carrie? Has widespread effects? Oh, it would be both. Because think about it. If your thyroid hormone acts on every cell, that means if you have too much, it's going to act on every cell. If you have too little, it's not going to give the instructions to all your cells. Do you see what I'm saying? So, regardless, your symptoms are going to be very, very widespread. Okay. So, if it's a congenital hypothyroidism, which is a creatinism, it's probably because you don't have a working thyroid, because it didn't develop properly in utero, right? And in terms of your acquired, it could be Hashimoto's, right? Like Andrew just asked, or it could be because you removed or ablated your thyroid, right? Because you had hyperthyroidism, or it could be you have an iodine deficiency. Okay. So creatinism is a congenital hypothyroidism that can be endemic due to iodine deficiencies. Not here in the US, right? Because, we've got iodinized salt here, so we don't have to worry about that. Um, but it could be due to the fact that the mother has Hashimoto's during pregnancy, and or has Hashimoto's and then is not treating her Hashimoto's and then gets pregnant, so she can't give the fetus the thyroid hormone that they need in the first trimester. Okay, it could be sporadic or genetic, but either way, because the thyroid hormone is essential for normal central nervous system development, mental retardation is one of the number one clinical manifestations, and you need to be able to replace the hormone therapy as soon as possible, or severe mental retardation will kick in for these individuals. In places where you have iodine deficiencies, like in the Himalayas, what will end up happening is the mother will not be able to pass on iodine to her fetus, and that will cause for lack of thyroid hormone being made with the fetus, or before the fetal thyroid is actually made, it's not developed and it's not formed properly until the second trimester. So it uses the mom's thyroid hormone in the first trimester. So if the mom doesn't have any thyroid hormone to give, then you're going to see symptoms like delayed nervous system development, delayed skeletal system development, severe mental retardation. They're going to be very short in stature. They have very coarse facial features. They've got this protruding tongue, which makes it very difficult for them to feed. right? So if the mother is lacking thyroid or has an iodine deficiency during the pregnancy, the severity of that in utero hypothyroidism is more. The severity is more the longer the mother is without the thyroid hormone. Okay. Um, if the deficiency is like in the third trimester, it's not as bad. So they need to be supplemented with the thyroid hormone, Cheyenne. Actually, so typically it's going to be the thyroid hormone you supplement them with. But if you're talking about a situation where it's a country that they have an iodine deficiency as their issue, you could replace the iodine itself in the diet. But I mean, at a time like that where the pregnancy is already ongoing, you just give them the thyroid hormone. It would be easiest at that time, or quickest. Yeah. So either way, early diagnosis is essential, right? So early treatment is essential. You want to be able to treat, before 3 months. Because if you do, then you have, growth and development can actually happen normally for these children. If not, they're going to have these skeletal abnormalities. But typically the skeletal abnormalities can improve with treatment. So overall, if we're dealing with a primary hypothyroidism, like we said before, iodine is essential for the T4, T3 synthesis. So if you don't have the iodine, you won't be able to make the hormone, right? However, if you guys recall from the previous chapter, there's a protein known as thyroglobulin that's important for the thyroid hormone development. And the thyroid will still make thyroglobulin even if it lacks the iodine to be iodinized to make T3 and T4. So what ends up happening now is, if you have like a primary hypothyroidism, you don't get the iodine that you need to make the thyroid hormone, but the thyroid keeps making thyroglobulin anyway. So it makes all this thyroglobulin in the follicles and it causes for the thyroid to increase in size. Okay. Especially because it's a primary hyperthyroidism. What do you think is happening? Your T4 is low, your TSH is high. So the TSH keeps telling the thyroid, here, make more, make more, make more. But guess what? You don't have any iodine. So all it's really making more of is thyroglobulin, and that causes the thyroid to swell. And then when it does, you get a goiter. So people can have a goiter whether they've got hypothyroidism or hyperthyroidism, right? Because in a hyperthyroidism, you're making so much thyroid hormone that you make a lot of thyroglobulin, which swells the gland, right? But in a hypothyroidism, even if you don't have the iodine, you still got to make the thyroglobulin, so it swells the gland as well. So you have a goiter in both. So if you lack an iodine, you have the goiter, right? And like I said, that don't really happen over here very much in the US. We have lots of iodinized salt, so we don't have that problem. But there are other areas in the world where, lack of iodine can be endemic. So goiters are basically enlarged thyroid, right? And typically because the thyroglobulin inside the thyroid follicles are basically increasing, and that causes for you to have that swelling of the thyroid, which is really found in the anterior portion of the neck, so you can really see it there. There are actually some vegetables that are goitrogens, which interfere with the thyroidal uptake of iodine and interfere with the function of the thyroid, making you get an actual goiter. But I mean, you really have to be eating like a shit ton of Brussels sprouts for that to happen. But it's possible, You know what are not goitrogens though? Fruit, yummy fruit. Those tend to not cause that issue. Okay, so if it's a secondary hypothyroidism, right? What's the issue? The issue is coming upstream of the thyroid. So that means the issue is coming from the TSH stimulation. So it could be because, there's some kind of trauma to the brain or the head, right? And as a result of that, you don't make enough TSH. So if you don't make enough TSH, how can you stimulate the thyroid to make thyroid hormone? You don't. So you get a hypothyroidism that's secondary. Does that kind of make sense, guys? Okay, so all in all, I mean, this is a whole bunch of clinical manifestations. You could memorize them all if you want, but I mean, if I was in this class, I wouldn't. I would just say to myself, okay, in a person who has hypothyroidism, that means their basal metabolic rate is so low, right? That metabolism is slowed down. What happens when someone's metabolism slows down? Okay, they're weak, they're lethargic, they're cold all the time, they don't have a lot of appetite, right? Their heart rate is slow, their pulse rate is slow because their metabolism is slow. The lipids increase in their blood, so they've got elevated triglycerides, elevated cholesterol. Their skin is very dry because they're not sweating, because they're not metabolizing. They're depressed. Their periods are very heavy, and if it happened as an infant due to congenital hypothyroidism, they've got all these symptoms plus the fact that they've got the umbilical hernia, the central nervous system manifestations as well, the protuberant tongue, the slow feeding, all of that. Does that kind of make sense, guys? Okay. So Hashimoto's is probably what you guys think about when you think about hypothyroidism because it's very common. It's when it's I think it is the most common acquired hypothyroidism here in the US. And it's when antibodies go in and destroy the thyroid and lymphocytes go in and invade the thyroid. So basically, you have destruction of the thyroid, and the patients will have a goiter. It's pretty common, and because it's an autoimmune disease, it can occur with other autoimmune diseases as well. Another way Hashimoto's likes to occur is during pregnancy, all right? And like I already told you guys, pregnancy and pregnancy and hypothyroidism not good, right? Because if you don't have enough thyroid hormone in the first 12 weeks, it's not good for the baby, right? Because the baby is using the mom's thyroid hormone in the first 12 weeks in order to generate, a healthy nervous system, right? And then once the second trimester come and the thyroid is fully developed for the baby, then it can utilize its own thyroid hormone. But in the beginning of the pregnancy, it's important that the mother has thyroid hormone. So the onset of the disease is about 30 to 60 years old, and as it's autoimmune, it's probably more common in females than males. And then the patients, they've got low T4 and high TSH. Why? Can you guys tell me why someone with Hashimoto's would have low T4 but a high TSH? Can you think of a reason why? Right, it's part of the negative feedback, right? The TSH is trying to get it to make more, but it's like falling on deaf ears, you know what I'm saying? And we already know what the symptoms entail, okay? That cold intolerance, that dry skin, that weight gain, that, puffy edema. Shannon, it's not even just that Hashimoto's is so common, it's autoimmune diseases in general that are so common, because I think Graves is like one in every 500, no, like one in every 200 people or something like that. So autoimmune diseases in general are so common, and it's because so much can trigger the immune system to just go crazy. Anything from just genetic correlations to fluctuations in the hormones, and then to viruses that may cause triggers of the immune system to go crazy. So autoimmune diseases in general is just common. And that's pretty much the reason why. Okay, so Andrew's asking is there's family inherited. Well, people who have thyroid disorders often have other either family members with other autoimmune diseases or like a thyroid autoimmune disease as well. Yeah, because a lot of autoimmunity have to do with like a lot of HLA correlation. So you come back to that family inheritance type vibe. Yes, yeah. So what happens when you have Hashim, Hashimoto's. When you have hypothyroidism and you just don't take care of it, like you have it for a really long time and you don't take care of it. Well, let's think about it. If you've got low metabolic rate from regular low thyroid, can you imagine for having low metabolic rate from low thyroid hormone for a really, really long time? So your bradycardia becomes heart failure. You know what I'm saying? Your your um your lethargicness becomes like a coma. You know, you just have this prolonged thyroid deficiency, and then everything just kind of, slows down so much. Your mental state is altered, your thermoregulation is so low. You have this potential to fall into what's called a mixed edema coma, which is obviously life threatening, because your heart is just not beating as it should. So your symptoms could be anything from like mental sluggishness, cold intolerance. The patients become very obese. They have a lot of glycosaminoglycans depositing in the soft tissue, giving them kind of like that whole creatinine, not creatinine, sorry, creatinism type of features to them. Their heart enlarges, over time, and, the patients are at risk for things like heart failure. So if you have a primary hypothyroidism, T4 is low, TSH is high. If you have a secondary hypothyroidism, T4 is low because TSH is low. Everybody's okay with that? So what's your goal? Your goal is try to get things back to normal, right? So how do you get things back to normal? You give the drugs that you give the hormones that you don't have in the form of a drug. So you can either take it orally to replace or supplement the hormone production. And if you're in something like a mixed edema coma, then you probably would have to take it via IV, right? So Olivia, what am I repeating? Oh, okay. Well, let's think about it, right? Let's walk it through together, right? Well, let's think about it. If you're so here's my anterior pituitary, here's my thyroid, right? Primary versus secondary. If my T4 is high in a primary disorder, my anterior pituitary is working just fine. So negative feedback is going to shut down the production of TSH, making TSH low. Does that make sense? Okay, right? But we're dealing with hypothyroidism here. So in that case, this is low. So that's going to send a message to my anterior pituitary that's working just fine, saying increase. Okay. So if it's secondary, right, you would go from the anterior pituitary. So in a situation of a secondary disorder, you would say that something is wrong upstream, right, of the thyroid. And as a result of that, you get low TSH. Doesn't trigger the thyroid at all, so your T4 is low. Okay, does that make more sense, Olivia? Cool. And to answer Ryan's question, they don't normally do that, treat it with immunosuppressants, because I don't know if you guys know this, but immunosuppressants really screw you over. Like it literally depresses your immune system. So when you're giving someone immunosuppressants, you really have to outweigh if the pros, and outweigh your pros and cons, because when you get something like an immunosuppressant, your immune system is suppressed, which puts you at risk for things like infection. It would be a lot easier when you've got something like Hashimoto's to just take the replacement thyroid hormone instead of suppressing your whole entire immune system. You know what I'm saying, Ryan? But that's a good question. It's insightful to think about that. Yeah. Okay. So you treat it, replace the thyroid hormone, you know, something like an immunosuppressant. There are just too many side effects. It's just too many complications with immunosuppressants to put someone, especially because like pretty much everybody, it's so common to have a hypothyroidism, you know, it doesn't make sense to put them on something like that. So anyway, if you have a hyperthyroidism now, we're in a situation where the T3, T4 levels are high. So if it's primary, T4 is high, TSH is low. If it's secondary, everything is mediated through the TSH. So the TSH is high, making the T4 high as well. Right. And then, of course, if it's autoimmune, like Graves, right, you have here's your thyroid, here's your TSH receptor. You know, TSH would normally bind to the receptor, making the gland release the thyroid hormone. But when you've got Graves' disease, right, basically what ends up happening is you make these auto antibodies that bind to the TSH receptor and stimulate it to make thyroid hormone. So you've got TSH plus the autoantibody. So you end up making lots of thyroid hormone. So you go into a hyperthyroidism. So like I mentioned before, it could be due to a pituitary adenoma, right? Or a thyroid carcinoma, right? So if it's a pituitary adenoma, it is primary or secondary, guys. Your hyperthyroidism. Secondary, okay? And if it's that thyroid carcinoma, is it primary or secondary? It's primary, okay? And if it's autoantibodies that are stimulating TSH receptors on the thyroid gland, like Graves' disease, is it primary or secondary? It's definitely primary. Very good. All right. So if someone has a hyperthyroidism, you know, are you going to memorize all these manifestations? No, too much work. Just think of a hyperactive person. Okay. When you think of a hyperactive person, their baseline metabolic rate is increased. So they're losing weight, even though they may be eating a lot. Their skin is warm and flush because, you know, their metabolism is so high. They're hot all the time. They're excessively sweating. Their gut is in overdrive. So it's hypermotile. So they're not absorbing very well. So they've got lots of diarrhea. Their heart is consistently palpitating, lots of tachycardia, they're nervous, they have tremors, they have muscle weakness, their menses is very scant, and if they have Graves' disease, they've got something extra. They've got what's called this exophthalmos, which actually is this very wide-eyed stare, which comes from their sympathetic nervous system just being in this crazy overdrive. And then they've got these deposition of like adipose tissue and glycosaminoglycans under the orbit, which causes for the eyes to literally bulge, which is called the exophthalmos, right? And the eye muscles become very weak, and they've got these bulging eyes. So typically, if a patient comes in and they show symptoms of hyperthyroidism with the bulging eyes, it's very easy to diagnose them with Graves' disease, right? They also tend to have like this coarse kind of orange peel-like skin, as well as all the other symptoms associated with hyperthyroidism. So as you can see here, TSH binds to the TSH receptors, but autoantibodies bind to the TSH receptors as well. So you just got this overstimulation of the actual hormone. So here are the long list. Okay, you've got a goiter, yes. Your menses change, right? You know, everything is so sped up. You're like have this hyper metabolism, so your menses is very scant, right? You know, you have lots of diarrhea, you know, you're anxious, you're irritable, you have a tremor, you know, you're warm all the time, you know, you're losing weight even if you're eating normally. And if you've got Graves' disease, you've got that not excess, you've got that extra symptom of the exophthalmos. So why, so you know, that's a good question, Cheyenne, and it does kick in. So you know, how about this? If we're looking at the diagnostics for Graves, the T4 is elevated, but the TSH is low. So it does kick in to lower the TSH, but it's just not enough. Because remember, in Graves' disease, it's not the TSH that's forcing, let me go back here a second. It's not the TSH that's making the thyroid make excess hormone. It's the autoantibodies. So even if I decrease my TSH, these other guys are coming at the thyroid with a vengeance. So they're still going to stimulate it. Does that kind of make sense? So the TSH does lower in, an effort to try, but I mean, it's not enough. Okay. So if you've got all this excess thyroid hormone, you're going to have to be able to treat it by like, decreasing how much thyroid hormone is actually produced, or removing the thyroid, or radioactively ablating the thyroid. And just like with Hashimoto's, there's also pregnancy with Graves. The HCG can mimic the TSH. So the HCG in pregnancy can mimic the TSH. So, now you're thinking about the fact that you got this hyperactive metabolism while you're pregnant. That's no good. Now your blood pressure is going to be too high. You probably suffer from preeclampsia, put you at risk for things like miscarriage and premature birth, right? So, the diagnosis of Graves can be very easy. You can see someone and just know they have Graves, but you want to do the diagnostics, which would be the elevated T4 and low TSH. So if you're comparing the two, Graves and Hashimoto's, you're really just looking at like a hyperactive metabolism versus a hypoactive metabolism, right? And that's where your symptoms would really come in. So you think to yourself, even though they're both autoimmune, one has an increase in your basal metabolic rate and one has a decrease in your basal metabolic rate. Okay. So some patients suffer from what's called thyroid storm, which is an acute severe exacerbation of your thyroid going super crazy. And it's a medical emergency because think about it. If your heart rate increases with increased thyroid hormone, imagine if what your heart rate is going to be like if it's severe and acute, right? These patients are at risk for cardiac arrhythmias and, sudden cardiac death. Their hepatic system goes crazy, their renal system goes crazy. There's like a surge of catecholamines, which causes for like that just cardiac arrhythmias, and their body temperature gets to be so high that their enzymes denature. They're nauseous, they vomit, their liver gets inflamed and causes for jaundice to occur. They're restless and agitated. Some patients even develop psychosis, right? Because everything is just in overdrive. So if you're diagnosing your hyperthyroidism, right, remember, it's going to be, if it's primary, it's going to be increased T3, T4, diminished TSH. Okay, so you're going to want to treat it with either reducing how much hormone you have circulating, right? So inhibiting the amount of the amount of thyroid hormone you make, or reducing the formation of the thyroid hormone. You might treat the symptoms by, giving beta blockers to slow the heart rate down. You could surgically remove the thyroid. Right. Once you do that, the patient now has hypothyroidism. So you have to give them replacement hormone. And then you could also do the radioactive iodine, where basically, it's given in liquid form. Oh my goodness. Can you guys hear my dog snoring? She's like sleeping in the other room. It's very loud. I don't know if you guys will hear it. But you're now radioactive, right? So, even if so the iodine will just head to the thyroid tissue. It would destroy the thyroid. You pass it out in your urine in a few days, but, you're radioactive at the time. Oh, you can't hear her? Do you hear her now? I know. And what's the worst part? She's so freaking like graceful. Like when you see her, she's so like, she's beautiful. She's like this graceful, like really regal kind of vibe to her. The way she walk, the way she sit. My neighbor, every time she sees her run, she's like, oh, she's like a graceful horse. Yeah, but she's down there like snoring like an old man that's drunk. Anyway, so don't mind her. So anyway, so there's like I know she does exist. I'll show you guys to her one day. I'll turn on the camera when she's awake one day and then show you to her. So you can't kiss anyone, you can't have sex, you can't sleep with anybody, and beside anyone. You can't share meals or utensils or dishes. when you're radioactive, right? Because you're radioactive. You're just trying to get rid of the thyroid and ablate it. All right. If you have thyroid storm, you have to aggressively treat the thyroid storm. You have the anti-thyroid drugs, you've got the beta blockers, you got the antipyretics to decrease the high fever, and then they're sweating so much, you have to replace their fluids, and there's so much inflammation, you got to give them glucocorticoids, so yeah, that's how that works. Okay, so let's do a little case together, right? So if the radioactive treatment if you're well, so that's a really good question, Dan. So it really just depends on the patient. It depends on the severity. Sometimes it's easier to just radioactively ablate it than to put the patient under and undergo, like surgery. But either way, you still have to leave the patients on the meds regardless. Yeah. Regardless if they do surgery or ablation, they still have to go back on the replacement therapy because you've ablated their thyroid. Yeah. Yeah. So depending on the patient, you might assess the surgical risks. Yeah. All right. So let's do this one together. So here we have Marty. She's 26. She's training to run her 5th marathon. She's got dyspnea on exertion. She's shortness of breath. She's fatigued. She has weight gain, even though she's running. If you've ever trained for anything before, if you're training for a marathon, you should not be gaining weight, no matter how much she eats, because that's just so much damn running. She doesn't have any children. She's not pregnant, but they suspect she has a thyroid disorder. What do you guys think she has? You think she's got hypothyroidism? Okay, so tell me, how are you going to be able to choose between whether it is what am I saying? Secondary or primary? Yes, we look at our TSH and T4 levels. Okay, so if she is primary hypothyroidism, what does her T3, T4, TSH look like? What does her T4 and TSH look like if it's primary? So if she's primary, she would have a low T4, high TSH. Okay, what if it's secondary? What would it look like? Both would be low. Okay, so let me ask you guys a question now. So she comes in to see you. What other symptoms are you going to ask her about to do like a patient history? Like what are some things you're going to ask her that has been happening to her besides obviously the weight gain and the fatigue? Yes, we could ask about her cold intolerance. We could ask if her menses is heavy, or if it's scans, it should be heavy if she's got hypothyroidism, right? What else could we ask about? If she has any family history of thyroid disorders. Yeah, that's a good one. What about her GI system, right? It's probably super slowed down. So she'd probably be constipated. She'd be mentally sluggish. Absolutely. Very good, guys. Yeah, very, very good. I like it. Okay. So she comes in and what does she look like? Like, if you were looking at her, like, how would she, like, what would you find on examination? Her skin would be dry, possibly a goiter, right? She doesn't make a lot of oils, so she'd have very brittle hair. She'd probably have like a non-pitting edema. She may be pale, yeah, because her heart rate and pulse rate may be low. Very, very good. All right. Okay. So let's say we say, all right, she have hypothyroidism. We're gonna put her on thyroid replacement, right? Thyroid hormone replacement. So do you think it's important for her to know the signs and symptoms of hyperthyroidism, even though she has hypothyroidism? Dan's like, of course. Okay, then why? You guys are funny. Like, why is this so important? She's got hypothyroidism. Why should she care? Because hyperthyroidism is bad too. Yeah, but like, Why? Why are we telling her about this? Because if the dose is too high, exactly, right? If the dose is too high, right, we can change it. Very good. Very good. I like that. Good job, guys. Okay, so you mean, you guys can kind of figure this out. Oh, I have one more question for you guys. How could I forget? Do you think she's at risk for thyroid storm? Really, Danielle? Yes, dot, 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 question mark. That's how we roll now? No. Okay, that's not how we roll. We think about these things and we answer with confidence. But let's think about it first. Marty has hypothyroidism. Do you think she's at risk for a thyroid storm? What's thyroid storm? Not even if her dose is too high I mean, how long would she be on this dosage? You know, I don't think it would put her in thyroid storm. She'd have to take the whole bottle at once. I would have to agree with Andrew on that. Yeah. But her thyroid storm, she wouldn't be at risk for thyroid storm. No, right? She wouldn't have that increased risk for those catecholamines to be circulating like crazy. But if she didn't treat her hypothyroidism, what could she potentially be at risk for long term? The heart failure due to what? The mixed edema coma. Very good. Very good. Yes. She would have to be on the medication for life, Olivia. Because as long as her thyroid is being attacked and it's damaged, she would have to be on it for an extended period of time. Okay, so if it's that you guys would make tables or charts, I mean, I don't know. Just try to we gotta try to order. Oh, now I know why the dog was so loud. I didn't realize she came into the room. I thought she was outside this whole time. I just turned around and she's like across the room from me. Makes sense why she was so loud. Yeah. So, make the chart, compare hyper to hypothyroidism. You might want to do that. Oh, she's so cute. Okay. So let's look at some adrenal disorders, right? So let's look at the adrenal gland first. The fact that it has an adrenal cortex and adrenal medulla. The cortex has 3 zones. First zone for mineralocorticoids, which is your aldosterone. Second for your glucocorticoids, which is your sugars, your cortisol. And then for your androgens, which are like your sex hormones. And then the adrenal medulla, right, has the catecholamines, and the catecholamines would be like your epinephrine and your norepinephrine. Those would be like your main hormones that are associated with your adrenal medulla. So if we're looking at disorders of the adrenal cortex, you could have a hypoadrenalism, meaning that everything is, you have like low adrenal hormones, or you could be hyper, meaning you have excess adrenal hormones. So in a primary adrenal insufficiency, right, which is a very specific disorder known as Addison's disease, every single thing in the cortex is low because the cortex is damaged. So your androgens are low, your mineralocorticoids are low, and your glucocorticoids are low. If it's secondary, right, it's something upstream of the adrenal gland making this happen. So it could be low ACTH, low CRH, if it's a situation where the pituitary or the hypothalamus is not working very well, okay? If it's low aldosterone, it could be because the person has like really high blood pressure that's chronic, right? Causing for them to have trigger the adrenal gland to not secrete aldosterone. Does that kind of make sense, guys? That would be secondary. And then if you have a hyperadrenalism, that's too much. Maybe you've got too much cortisol, which is Cushing's. Maybe you have too much aldosterone, which is Conn's. Maybe you have a congenital hyperplasia where you're just making too many adrenal hormones. Okay. So here's something to think about, right? So let's say your cortisol levels are low. If your cortisol levels are low because your adrenal cortex is not functioning very well, because of negative feedback, it's going to send a message to your anterior pituitary telling your anterior pituitary to increase your ACTH. So ACTH and MSH have the same starting product. So typically, when you have an increase in this starting product, right, when the ACTH is forced to be increased, right, you actually, as a side effect, get an increase in a hormone known as melanocyte stimulating hormone. So a lot of times when your ACTH increases, your pigments actually increase as kind of like a side effect of that happening. So you'll see with disorders where the cortisol has fallen that the patient tends to have like a hyperpigmented skin as well. So you can look out for that in the manifestations associated with, for example, Addison's disease. So when someone has Addison's disease, right, typically they've got a disorder that has destroyed the adrenal cortex. So the adrenal cortex can be destroyed from infection to trauma to neoplasms to autoimmune disease. Regardless, what's happening here is a lack of all of the three groups of hormones associated with the cortex. So low androgens, low mineralocorticoids, low glucocorticoids, right? Low salt, low sugar, low sex. That's just the way it's going to be for these patients. Okay. So in terms of Addison's, JFK had Addison's actually. And let's start thinking about the manifestations. So if you've got low androgens, right, that means he's got low testosterone. So if we were treating JFK, we'd have to have him on testosterone replacements, right? If he's got Addison's, his mineralocorticoids like aldosterone is low, which means that he's not bringing back a lot of sodium, which means he's not bringing back a lot of water, which means his blood pressure is very low. Does that make sense? So he has low salt, low blood pressure. Okay. He also, because he's not bringing back a lot of sodium, he's not excreting potassium, which means potassium increases in the blood. And if potassium increases in the blood, that's a surefire way to go into cardiac arrest. So he's at risk for cardiac arrhythmias. All right. His blood pressure is low, his salt concentration is low, his cortisol is low. If your cortisol is low, what's one of the prime effects of cortisol? Gluconeogenesis. If you don't have these glucose that he's making, what's going to end up happening? His sugar is going to be low, which means that he's going to be chronically fatigued. Do you see what I'm saying here, guys? That's how you have to kind of think about it, right? So he's got low blood pressure. Oh, and if he's not retaining water because of his lack of aldosterone, he's losing water. So he's probably dehydrated, right? Especially from that sodium wasting that's going on. So, just think to yourself there, you could study Addison's and just make a long list, or you could just think to yourself, what's going on with these patients who have Addison's disease? Like, they're missing certain hormones. What do those hormones do? Right? And if they don't have them, how is that going to manifest in the patient? So by the time we had the Missa crisis, right? JFK was on hydrocortisone for all the inflammation. He had he was on testosterone to replace his androgens. He was on salt tablets to replace his salt. He had to control his blood pressure. He had to boost his energy. I mean, because his cortex was just ablated. He just didn't have a very good cortex. Okay. If we're thinking about adrenal cortical insufficiencies that are secondary, it has to come from something upstream of the adrenal cortex. So for example, it could come from the hypothalamus and the pituitary, but in that case, it would only be ACTH and cortisol. ACTH and CRH to manipulate cortisol if we're talking about coming from the hypothalamus, because aldosterone is triggered by what? What do you guys think? Yeah, aldosterone is triggered more by blood pressure, blood volume, changes in sodium and potassium concentrations. So if there's a situation that's causing an adrenal insufficiency and it's coming from the hypothalamus or the pituitary, then it's definitely going to be affecting cortisol more than anything else. Right? So that's how you have to kind of think about it. Does that kind of make sense, guys? Yeah. So if it's just cortisol that's affected, okay, then these patients would have only symptoms associated with decreased cortisol. They wouldn't have symptoms like hyperkalemia, right? For example, like with the patients with Addison's, because aldosterone isn't affected by the hypothalamic pituitary pathway. Does that make sense, guys? Yeah. Yeah. So that's how you have to kind of think about it, because it is a lot of information to digest. So you kind of don't want to be like, okay, I'm gonna just study this and I'm gonna study this. It's be too hard. Aldosterone is stimulated by angiotensin 2. Yes, Leandro. So we only see increases in hyperpigmentation associated with primary adrenal gland issues. Um, not just primary adrenal gland issues, but those that are associated with a decrease in cortisol. Because if it's just a decrease in aldosterone, it wouldn't cause any kind of trigger of MSH. You see what I'm saying? Yeah. Yeah. So you have to think about it like that. Okay. So some patients go into what's called an Addisonian crisis, where let's say they're going to do surgery and they've been on like steroids for a long time. Like maybe they have asthma, so they take steroids for their asthma. If they have to do surgery, typically what would have happened is because they were on steroids for such a long period of time, right? Their pituitary already knows that they're on steroids. Okay, so it's adjusted to that. So essentially, your pituitary is not releasing a lot of ACTH at that time when you're on this long-term steroids, because there's no need to. I mean, you're on like this drug, and there's no natural manipulation that's occurring. So what they have to do is they have to take them off the drug like little by little, right? Because they have to steroid taper them for the surgery, because what's going to end up happening is if they just take them off the steroids for the surgery, they go into like an Addisonian crisis where they have like no ACTH to stimulate because their ACTH was already suppressed long term due to the fact that they were on these steroid drugs already. So anyway, if we're talking about like Addison's, okay, we already talked about the symptoms associated with Addison's, and it makes sense to us, right? The sodium wasting and potassium retention, which could lead to metabolic acidosis, and that's all coming from the aldosterone lacking, right? The melanocyte stimulating hormone being increased because of the ACTH having the same precursor, right? So the hyperpigmentation. They've got changes in their electrolytes, disturbances, they've got weight loss, weakness, right? They don't want to eat, their blood volume is low, their cardiac output is low. They can go into what's called a cardiovascular collapse. So how do you diagnose them? Well, lots of different ways, right? Obviously, physical examination, patient history. We can look at the cortisol levels. We can look at the ACTH levels to see how the adrenal glands, reacts to ACTH. We can do a CT scan or MRI to look at the adrenal glands. And then what do? We replace what's missing, right? So aldosterone is missing. We replace with salt tablets. Cortisol is missing, so we replace that. And then because cortisol increases most in the day and then tapers off in the evening, you kind of do the dosage like that, where you mimic the dosage as well, right? And of course, if they're in any kind of crisis, you want to use IV drugs instead. Yeah. Okay. Do I want to do this now? Let me see what we got popping off over here. I could do Cushing's. I think I'm actually gonna stop here, only because I feel like the adrenal gland gets kind of tricky. And if I like shove thyroid and adrenal down your brain all on the same day, it kind of gets like loopy doopy. You know what I'm saying? So let's stop here today. I think we have enough time to make it through the rest of the chapter next week. Does that make sense, guys? Everybody's okay with that? Cool. Oh, since we finished early, I'll let you see my dog for 2 seconds. Come here, Rhea. Oh, Pookie, the kitties want to see you. Let's see, where is the video? Oh, I have to stop sharing.